very beginning, very disciplined person, and still very kind-hearted and very lovable guy. So we used to call him JC only, and still he's JC to us. Again, he's presenting on heart failure with preserved ejection fraction. So that is something about which we are eager to understand that do we still have any treatment, or it's still, companies pushing drugs in a place where nothing is there to offer. Over to you, Jay.
Okay, sir. Excuse me. Good evening. So good evening to all of you. Dibya, Jyoti, sir, good evening.
Excuse me.
Yes, sir.
Can I have
Okay, Datta, good evening.
Yeah. Actually, I have been for a long time away from this forum. I have seen so many familiar faces. Dr. Smith, Dr. Sunip, he was my batchmate, of course. And I should congratulate Dr. Smith for organizing such a nice discussion. Because when we were DM student, that time also diastolic heart failure was a very hot topic for examination. And even after so many years, honestly, actually, I don't know much about this, what to do about that. And it's a very good topic. And I think Dr. Jayachandra is the best person to throw his knowledge and light on this subject. Thank you very much.
I'll also request you to introduce the experts, because I was in a hurry of getting the slides projected. So I actually bypassed that protocol that we'll introduce.
It's all right. Protocol is not required.
Yeah. That's fine, but it's still, sir, we'll know each other. That's a better way. I was more worried that I get these slides on show.
Yeah.
So, sir, we have our experts, sir. Dr. Pranab Bhattacharya. He's a DM cardiologist from Guwahati. And Dr. Sunip Banerjee. He's DM cardiologist from Kolkata. Dr. Ashish Jha, who was there with us for a short while before. I think he'll be back. He's DM cardiologist from Lucknow. RLM or RML College. Dr. Prashant Panda, he was our junior in PJ Chandigarh, DM cardiologist Chandigarh. And Dr. Dibya Jyoti Datta from Guwahati, and Dr. Saujatya Chakraborty. These are our panel of experts. So I'll start the presentation, sir, without much delay.
Right.
So next slide, sir. So we are talking about heart failure with preserved ejection fraction and its management. So before going for the management, we need to define this entity very properly. So the classification is based on either the ejection fraction or the progression or the time course or the location of the heart failure. So based on the ejection fraction, which is the common modality, we have a reduced ejection fraction, which is less than 50%. Preserved ejection fraction is more than 50%. Now, there are some entities called recovered ejection fraction. People who are in systolic heart failure can recover and go into diastolic heart failure subsequently. And also we have something called a mid-range heart failure, mid-range ejection fraction, that is from 40 to 49. So based on the progression, it can be acute or stable or worsening or new onset, chronic or transient. And location-wise, usually it is left-sided, but sometimes it can be a biventricular kind of picture also, stiffness in both right and left ventricles. Next, sir. Next slide, sir. So the cardinal differences, if you see an autopsy, so previous slide, sir. If you see the autopsy findings, the cardinal difference between a systolic heart failure and a diastolic heart failure is an eccentric LV remodeling in systolic heart failure and a concentric LV remodeling in diastolic heart failure. There is a low LV mass to volume ratio and high LV mass to volume ratio. Next slide, sir. So as per the 2021 ESC guidelines, a patient who has symptoms and signs of heart failure with an ejection fraction on echocardiogram of more than 50%, with an objective evidence of cardiac structural functional abnormalities like the presence of a diastolic dysfunction or elevated end-diastolic filling pressures or LV filling pressures, including raised natriuretic peptides. So this is the definition. But the problem is that heart failure with preserved ejection fraction is not a single entity. It is a very heterogeneous clinical syndrome as a result of many different pathologies. Next slide, sir. So this is just an example of a normal heart which is compliant, like a balloon, whereas a stiff heart, which is like a football, you can only fill that much. It cannot fill beyond that. So beyond that, it is likely to, kind of offer a lot of resistance. And as a consequence of marriage of heart to the lung, there is a pulmonary congestion. So like I said previously, it's a heterogeneous syndrome. The one size fits all recipe, which is there in systolic heart failure, cannot be applicable to heart failure with preserved ejection fraction. That means you cannot put the recipe of RA antagonism, neurohormonal blockade, all of them together like we put in the systolic heart failure. Like we don't have any guideline directed management in preserved ejection fraction. Next, sir. So if you see the risk factors, they are the important points. These are the things which are more important in preserved heart failure than anything else. The central point which you see in the nucleus is hypertension. Around the hypertension, you have CAD, aging, pulmonary hypertension, and obesity. And also the other risk factors like atrial fibrillation, anemia, COPD, frailty, diabetes, obstructive sleep apnea, and CKD. So these are the other kind of significant comorbid conditions. Next, sir. So we have certain phenotypes of heart failure with preserved ejection fraction. One is the aging phenotype. So we have community-based studies which showed that people who are very elderly, that is more than 80 years, have very high incidence of myocardial molecular dysfunction and eventually cardiac alterations which result in very easily they develop heart failure. The second phenotype is obesity phenotype, which causes as such an increased arterial resistance and obstructive sleep apnea, which contributes to the pathogenesis by causing hypertension. Next slide, sir. And the pulmonary there is another phenotype which is called the pulmonary hypertension phenotype, which is as a result of elevated LV pressure. And the funny part is the prevalence of pulmonary hypertension is much more common in heart failure with preserved ejection fraction than in systolic failures. So we generally expect systolic heart failures to have more PAH, but it is a diastolic heart failures which have the more incidence of pulmonary arterial hypertensions. And of course, the coronary artery disease is the kind of phenotype which coexists with so many other conditions. Like also in this condition, there is a range of 35 to 53% in large registries. We don't have data from our country, but this is from the other registries. Next, sir. So if you see the trends of prevalence of heart failure, the trends have been increasing since since 1900s. So you see that gradually with every passing 2-3 decades, it is because of increased screening, increased recognition, more aging population, like the average lifespan of the population is increasing, and also increasing obesity and hypertension because of the epidemic of hypertension, obesity. There is no food scarcity presently. So next slide, please. So to start with the pathophysiology, we have two pathophysiological process. One is the impaired diastolic dysfunction. The heart is, we all know, is a twisting of the heart which leads to ejection. At the same time, it has to untwist to relax, and this relaxation is impaired, which is also an active energy-consuming process. Also, because of various pathologies, there is a passive myocardial infiltration by either due to fibrosis or some infiltrative process, which leads to stiffening. And this stiffening leads to an irreversible kind of changes in the protein kinase G activity, and also there is a reduced nitric oxide activity, which results in the heart failure. Next, sir. So these are the proposed mechanisms, which finally the ones above are the risk factors. The ones below is the pathogenic mechanism as a summary, which I told you: reduced nitric oxide, decreased PKG signaling, increased myofilament stiffness, fibrosis, hypertrophy, calmodulin, protein kinase raise, and sodium overload. They all cause the diastolic dysfunctions. Next, sir. So finally, this pathophysiological process is going to affect the kidneys. It causes passive venous congestion, which can result in oliguria or acute kidney injuries or renal impairment. It results in skeletal muscle endothelial dysfunction, which impaired peripheral vasodilation, which leads to exercise intolerance. It leads to vascular stiffening, which leads to labile hypertension. It also leads to increase load on the lungs, which impair the respiratory muscle metabolism. And also in the abdominal component, there is a chronic venous congestion, which can lead to kind of endotoxemia. You can gut flora translocation can happen because of congestion of the gut. Next, sir. So also apart from the pathological phenotypes, we have certain clinical phenotypes wherein it has been observed that a certain subset of patients who are younger, they had heart failure, diastolic heart failure. These are the people who only had exercise. When they were at rest, they were perfectly fine. But when they exercised, they had increased LV pressure and they had a moderate diastolic dysfunction. But when they were resting state, they were perfectly fine. When you do their NTP, pro-BNP, they will be perfectly normal. The second phenotype is a slightly aged or middle-aged population with obesity, diabetes, and high prevalence of obstructive sleep apnea. These are called volume overload types. And the third type is the much more elderly patients with other comorbidities like CKD. They are the ones who have a pulmonary hypertension and associated RV failure along with the heart failure with preserved ejection fraction. Next slide, sir. So now very important thing is there is a term called phenocopies in heart failure. This is a new term. The phenocopy is clinically the same phenotype, but a pathophysiologically different. For example, we have so many other conditions which can cause infiltration, systemic diseases, which can cause infiltration of myocardium, like amyloidosis, hypertrophic cardiomyopathy, which can result in a similar disease process. So the importance in identifying the phenocopies is the treatment modalities. Like we were discussing, there is no single treatment for heart failure with preserved ejection fraction. It all depends on the etiological. It is etiological treatment. So if it is amyloidosis, you can try out some drugs. If it is HCM, you can try out certain drugs like mavacamten and all that. Next. So for phenocopies, examples are amyloidosis, cardiac sarcoidosis, hemochromatosis, sometimes low flow, low gradient aortic stenosis, and hypertrophic cardiomyopathy. Next, sir. So this is the diagnostic algorithm of heart failure. See, the mnemonic is PEFF, like we call heart HEF-PEF. So PEFF. P is the initial pretest assessment workup like ECGs and natriuretic peptides and echo and all that. In E, it is the echocardiographic and the natriuretic peptides, if not done in the step 1. In F1, which is the functional testing, in case of uncertainty, you can do an exercise stress echocardiography, or you can do invasive hemodynamic. If your patient cannot exercise, you can straight away do the invasive hemodynamic measurements. Like you can do the pulmonary capillary wedge pressures and all that. Finally, you have the F2, that is etiological workup in the form of cardiac MRI or cardiac biopsy or PET scan or genetic testing for certain amyloid conditions and specific laboratory tests for the conditions like sarcoid and all. Next slide. So when we approach the heart failure stepwise, don't miss the diagnosis. Firstly, if in doubt, perform the right heart catheterization and or exercise testing. And before treating, remember that there are certain rare etiological conditions which we should consider because they are refractory to treatment. Categorize the type of heart failure both in the terms of pathology as well as the clinical phenotype and work out a treatment plan. Then, as general treatment protocols, avoid fluid overload and salt overloading and treat hypertension. Comorbidities have to be addressed, like obstructive sleep apnea has to be addressed with a BiPAP or something aggressively, because BiPAP will address both OSA as well as your heart failure. And also tailor make the treatment to the phenotypic subtype. And if nothing works out, of course, you have to enroll in clinical trials. Hardly any clinical trials are conducted in our country on HEF-PEF. Next, sir. So as general, these are the various modalities which are available to us. But the problem is you can't use all of them. There are, like, if the patient is come with a creatinine of 2, you have to be very cautious with diuretics, ACE inhibitors. Beta blockers cannot be used in every scenario, like only in the scenario of AF or a tachycardia, flutter fibrillation. But otherwise, you should not be using beta blockers indiscriminately. Similarly, digoxin has got its own, contraindications unless the patient has got an AF or a compelling indication. Statins, of course, if there is an underlying CAD. So we will go in detail about these drugs, sir. Next. So basically, the treatment is avoid tachycardia. The tachycardia is the one thing which precipitates the heart failure with preserved ejection fraction. So you have to either control the heart rate or kind of put on preventive medication. Now the use of digoxin, beta blocker, non-dihydropyridine CCBs or amiodarone depends on the case-to-case basis. For blood pressure control, you can use ACE inhibitor, ARB, or mineralocorticoid antagonists, which may be of greatest benefit. Beta blockers are not to be used for blood pressure control, except unless to control heart rate or to reduce the angina in case of coexistent CAD. And optimize the comorbidities in form of dyslipidemia, obesity, and diuretics. There's a very important thing that loop diuretics have to be used very cautiously because they can really rapidly relieve congestion, but very rapidly precipitate AKI also. So unlike systolic heart failure, where you use very high dose loop diuretics, diastolic heart failure, it's only probably 1 or 2 doses, after which the patient rapidly improves. But the most important thing is once these patients are off the ICU or off the hospital, you have to improve their exercise capacity and quality of life, because ultimately it is the peripheral vasodilation which prevents the heart failure. So if you have a good peripheral runoff without any vasoconstriction, they usually, their capacity increases and their presentation also. Their LV and diastolic pressures also don't increase so much. Next, sir. So again, the same targets as in systolic heart failure, where all these, ACE inhibitor ARBs are targeting the angiotensin, aldosterone antagonists are targeting at aldosterone level, diuretics are targeting the, fluid and sodium, and SGLT2 receptors, they are also targeting the, sodium and, glucose co-transporters, beta blockers, and the same thing. But how to use them? I have given certain trials which have showed which is beneficial and which is not. Next. So the most important thing to remember is the drugs which are shown to cause a mortality benefit in heart failure with reduced ejection fraction have a doubtful benefit in preserved ejection fraction. So no drug has got a very clear cut, except probably one group of drug like SGLT2, which I'll come later. And sometimes some ARNIs have shown to have a little, kind of, it's not a randomized, it is probably some kind of independent studies like registries. They have shown them little improvement. Next. So when we see the ACE-ARB studies, mostly we have studies on candesartan, perindopril, and irbesartan, that is CHARM Preserve and PEF-CHF and I-Preserve. And all of these studies, they could not meet the primary endpoints. So basically, there's not much of data on ACE-ARBs unless there is a pure hypertension you are controlling, go ahead. But otherwise, just to treat the heart failure, there's nothing clear data. Next. There's a TopCat study wherein spironolactone, we all know, is a very important drug in preventing the LV remodeling in case of reduced, systolic heart failure. But in this study, where they studied patients, roughly around 3,400 patients, they found that compared to a placebo, the benefit of spironolactone is just about marginal. I mean, there is nothing very concrete in this use of spironolactone. However, if the patient has hypokalemia, definitely we should use it. Then we have an ALHAT sub-analysis on thiazide. This is one drug which has probably been shown to be much better. Like in case of like JNC recommendations, we have a thiazide diuretic which is recommended for any patient with hypertension, especially isolated systolic hypertension above 60 years of age. So it has been shown that chlorothalidone reduces the risk versus amlodipine by 31%, versus doxazosin by 47%, and versus lisinopril, which is an ACE inhibitor, by 26%. So thiazide diuretics are a viable first-line therapy. Now coming to beta blockers. So beta blockers, the problem with beta blockers is with reduced ejection fraction, they are of very much use, but in preserved ejection fraction, it all depends on whether the patient has got a tachyarrhythmia or he has got an underlying CAD. So there is a meta-analysis which shows that the treatment with the beta blockers is favored marginally only. There's not significant. Only independent studies show, significant improvement with beta blockers, but RCTs of, meta-analysis don't show. Meta-analysis of RCT don't show much of favor. It's little on the, favor side. Next slide, please. Now the issue is these people may concomitantly have coronary artery disease. But many times when we address these patients by angioplasty, they usually don't improve. They come back with the same symptoms. Because if an obese person who is 80, 90 kilos or 100 kilos, he is having OSA, you are putting an angioplasty, you're doing an angioplasty in LAD, RCA, but he will come back with the same symptoms because the same thing is the pathophysiology is the same. So you don't primarily do angioplasty with the intention of relieving the symptoms, but definitely high-risk angioplasties have to be, high-risk lesions have to be addressed. The rest is all treatment of CAD if there is coexisting, but definitely there is no clear benefit of improving this heart failure unless by other modalities like hypertension, OSA, AF rate controls. Next. So now we will talk about the novel therapies. So especially like these novel therapies, mainly we will talk about SGLT2 inhibitors, which are the new drugs, and ARNIs. Basically, they are supposed to address the volume overload, microvascular inflammation, cellular extracellular changes, and cardiometabolic anomalies, pulmonary vascular hypertension, left heart congestion with LV and diastolic pressures. Next slide. So now we will come to the main studies. Previous slides. So we have studies on ARNIs, which is Paramount, Paragon heart failure. So this Paramount study was done with the ARNI, that is Vimada, which is, it showed that the group which was given ARNIs, the anti-proBNP was significantly reduced compared to the group which, did not receive it, which received probably only a, ACE inhibitor or ARB. But the p-value is significant in this study. But in the Paragon heart failure, the primary composite endpoint were reduced but failed to reach a statistical significance. Now we come to the other studies, that is SGLT2, the DECLARE-TIMI-2, Emperor Preserved trial, and Preserved heart failure and deliver. These are all trials involving dapagliflozin or empagliflozin in the doses of 10 mg. And dapagliflozin was considered to be non-inferior to placebo in reduction of MACE, and the p-value was significant. This is the DECLARE-TIMI. And in the other studies also, there was a reduction in the primary endpoints. Next, sir. So ARNIs in Paragon heart failure did not result in a significantly lower rate of total hospitalization for heart failure and death from cardiovascular causes in patients with heart failure with ejection fraction of 45% or higher. This is the NEGM study which was published in 2019. Next. Now, this is Emperor Preserved trial, empagliflozin in heart failure. The conclusion was empagliflozin reduced the combined risk of cardiovascular death and hospitalization in patients with heart failure with preserved ejection fraction. It is irrespective of presence of diabetes. Even you may choose to use previous slides. You may choose to use SGLT2 inhibitor even if the patient doesn't have diabetes, like we do in case of systolic heart failure. As evidenced by the graph, you can see that there is a significant benefit. Next, sir. So there is the preserved heart failure, the SGLT2 dapagliflozin. Again, it improved the patient-reported symptoms, physical limitation, exercise function, and well tolerated. Next. So meta-analysis of all these SGLT2 inhibitors show that most of them are favoring the treatment. If you see on the hazard ratios, most of the trials which have undergone have shown that there is a beneficial this thing, but p-value has not been that significant, but most of them have reported a benefit. Next. So there's a new drug called sotagliflozin. There is a soloist WHF trial. This was kind of published in 2021. Again, it has also documented a significant improvement in patients with diabetes and recent worsening heart failure. Next. So now we have certain recent RCTs. Now we had the three phenotypes. If you remember, that young phenotype who had exercise-induced elevated LA pressures, but otherwise at rest they were perfectly fine. So this one reduced LAP heart failure. LAP is left atrial pressure, HF2. So they experimented with inhaled and oral nitrates, and a Panache trial which involved an adenosine-1 agonist. But they are not reported much of an improvement with this. Like, I'm just mentioning that what all agents have been tried so that we know that these were the agents which are not really effective. Like sometimes we tend to use NTG even for preserved heart failure. So it's not much of benefit. In type 2, that is obese patient with a middle age and a high volume status, again SGLT2s, ARNIs, and a drug called vericiguat, which is a guanyl cyclase inhibitor. These are the drugs which have, the ones which is shown in blue is the one which is proven that to be effective, but the ones in red is not proven to be effective. So type 3, we have talked about geriatric patient who have predominantly pulmonary arterial hypertension with RV failure. They have tried a drug called macitentan and oral treprostinil, that is a prostaglandin inhibitor, and levosimendan, which we already use for systolic heart failure. And in Candin's trial, sotanercept. This is again a kind of interleukin inhibitor. A little beneficial effects with Cadence, but rest of all of them have not shown any benefits. So as per the 2021 AC guidelines, so the screening treatment of etiologies, cardiovascular and non-cardiovascular comorbidities recommended for all patients. This is a class 1 recommendation with heart failure with preserved ejection fraction. And diuretics are recommended cautiously in order to alleviate the symptoms, congestive symptoms. But the level of evidence we have for all this is C level of evidence. Next. So another study which I would like to show, like many of us use a low dose dopamine and Lasix infusions, whereas it may work out pretty well in systolic heart failure, but it is shown that it may be associated with renal, continuous infusion of diuretic strategy associated with renal impairment. Next. To summarize, like these are the various treatment modalities. To summarize, it remains a challenging clinical syndrome to manage. Using the currently available therapies, patient can be optimized. Every patient has to be tailored to particular, whatever is his comorbid conditions. Based on that, you have to decide what you have to give. And defining the clinical phenotypes may help the management, a specific management. Like, is this patient having exercise intolerance? Is this patient having rest symptoms or minimal exercise intolerance? Even getting up and going to the washroom or something is breathless. So we have to kind of classify them and treat them accordingly. Next slide, sir. And it is also the challenge is it is associated with a because most of the patients are geriatric. Most of the patients are on the obese side, having comorbid conditions like COPD and atrial fibrillation. So we have, and anemia. Anemia is a significant comorbidity associated, which I have not mentioned here, which can as such precipitate most of the symptoms. So treatment of comorbid conditions which require specific therapies, and phenotype mapping to find out a condition which can be targeted with a novel therapy, or they can be enrolled in certain clinical trials. So we have to think about the rare possibilities which we usually don't think about. Next. So to conclude, heart failure is common in older population with comorbidities. It has got a pathophysiology and etiology management which is distinct to each phenotype and clinical subtype. The treatment is based on symptoms and comorbidities, and many effective treatments for systolic heart failure have shown disappointing results when applied to these patients. And most of the medications, except for are probably SGLT2 inhibitors or certain thiazide diuretics, most of the medications used to treat, they lack evidence of any mortality benefit. And new pharmacological targets like SGLT2 inhibitors may play a role in the optimal management of heart failure. And of course, we need to enroll such patients and do multi-center studies. We have so many OPDs running. We can always do multi-center studies and bring in more insights into this condition. Because I make a point every time patient comes to always do anti-proBNP on the OPD basis. And I keep tracking them as per the anti-proBNP. And if possible, we should do a 6-minute walk test, which is a very effective strategy. I know it's a very busy OPD. Most of the time, NYHA class is very subjective. We don't get the accurate NYHA class. So the more objective way of measuring the physical capacity is a 6-minute walk test. If you have a good trained person or a company, I used to keep a Novartis guy and I used to make him do the 6-minute walk test. I used to collect the data, and we had published certain studies also. So I'm done with the presentation, sir. So if there is any discussion, we would do. Thank you for the patient hearing.
Thank you, Dr. Jayachandra. Your presentation is very elaborate and very exhaustive. Actually, there are a lot of theoretical background is involved. So sometimes it's very difficult to make a comprehensive, conception regarding heart failure and preserved ejection fraction. So in your day-to-day life, how often do you used to get heart failure with preserved ejection fraction?
Sir, out of if I have 10 ICU admissions with heart failure, 3 of them are diastolic heart failures.
Do they have any specific comorbidities?
Specific comorbidities, sir. Most of them are having anemia, elderly, geriatric populations. Firstly, advanced age, underlying obesity with OSA, uncontrolled hypertension, anemia, definitely, sir. And some kind of rhythm abnormalities like having atrial fibrillation with fast ventricular rate, or these are the patients. Because when they come, usually they are admitted as systolic heart failure, because the MO or medical officer, resident, whoever sees, they admit them as systolic heart failure. But once we see the clinical conditions, the anti-proBNP, we do a bedside echocardiogram. We know that this is this is definitely congestion in the lungs, and definitely patient has features of pulmonary venous congestion on the X-rays. So they respond very rapidly to one single dose of diuretics. Usually they don't have that much of pitting edema and all that. They don't have that much of pitting edema, which we have in systolic heart failure. They don't have that much cardiac cachexia, which we have in systolic heart failure. So this is a very distinct subset of patients, and they respond very rapidly. And the best part is you can start beta block, you can start rate control pretty effectively. Like in systolic heart failure, we avoid rate control except until the lungs are dry. So here we are able to start from day 2 onwards, some calcium channel blocker if the EF is okay, or some ivabradine. So we also prefer ivabradine, which is a very good effective agent. Or if there is atrial fibrillation, digoxin or something. So in this situation, we rule out all the existing structural heart disease, like no rheumatic, nothing. It's only pure patients with a stiff heart, with at least a grade 2 plus diastolic dysfunction, grade 2, grade 3 diastolic dysfunction.
Yeah, of course, we have to, rule out or exclude or HFpEF mimics, like structural heart disease, SOCMN and all that. Actually, my point was regarding the clinical presentation. In HFrEF, we have a lot of clinical findings. You may not be remembering when we are medical students, there was in MBBS, there was a dictum, the 5 cardinal signs of congestive cardiac failure. That time it was a broad category of congestive cardiac failure. Now we have moved far away from those conceptions. Now we are discussing on the presence of ejection fraction itself, HFrEF and HFpEF. But the clinical findings still remain the same. But unfortunately, in HFpEF, those clinical findings are very rare. When we auscultate the chest, iron capitations, inspirated capitations maybe, but S3 gallop, which is a clinical hallmark of left ventricular systolic dysfunctions, which is not here. And plus your signs of passive venous congestion, which is also not very florid. So sometimes it is missed even. And erroneously, in emergency, resident used to inject diuretics, and many times people used to get some relief about that. And anti-proBNP measurement, how costly in your place, but it is not very easy.
Sir, ours is a government setup, and we have plenty of kits, and we doing like I've told, I put a protocol. Any patient coming with breathlessness in the hospital, in the emergency room, we have to do anti-proBNP first, because it is going to give us some clarity regarding what we are dealing with, rather than doing a lot of arbitrary treatment. Because they tend to inject Lasix to asthma patients, and they tend to nebulize the cardiac failure patients, so which is very detrimental. So I say you get the anti-proBNP, put him on oxygen. Let the lab report, the card test or lab report. It is very rapid test. We get the values. So we said, see the value and start. So many times there is a lot of confusion between a COPD, a heart failure, because the presentation is very similar, and most of the people are also smokers. So there is a lot of intermixing of etiologies and the presentation.
We have a patient with CKD here, and they have a very high anti-proBNP level. So in those situations, sometimes it's really difficult, whether it is a HFpEF mimics or associated HFpEF. So what is your response to treatment as you are offering to your patients?
Sir, generally we don't get those many because we are not a renal center as of now. We don't get so many CKD patients.
HFpEF.
Response to treatment, sir. Yes. It's very rapid, sir. We see by the same day, by evening, 2 doses of diuretics, they settle down very rapidly. They become.
Subsequent prognosis.
The prognosis is not good because they have multiple comorbidities. Otherwise, as an entity of that admission of heart failure, the prognosis, their hospitalization duration is much less compared to a systolic heart failure. The chances of them developing deep venous thrombosis, the chances of them developing some stroke and all that is very less compared to systolic heart failure. But because of the presence of multiple comorbidities, these comorbidities play a role in the overall morbidity or mortalities.
Yeah. At this point, please. Yeah, Dr. Smith.
Yeah. So another area where anti-proBNP you have to be cautiously in interpretation is obese patients. So obese patients can have other reasons for anti-proBNP to be deranged. So there you have to take caution. And then as in course of your slides, it was that right heart catheterization, RHC is the mainstay of diagnosis of diastolic heart failure. But I don't think any of us is now doing a RHC in our labs. So how do you how do you guide us that we can pick these things on clinical interview from the patient, which can be pointed to that we should start suspecting diastolic heart failure, one, and then subsequently what on echocardiography, E prime, and what else we need to pick up so that we define these patients as diastolic dysfunction or HFpEF patients.
So clinically, essentially, most of these diastolic heart failure patients, essentially they have an effort intolerance. Compared to systolic heart failure, who have generalized fatigue, generalized tiredness, but these patients are perfectly fine for low-grade activities. The moment we motivate them for a weight loss, so they get motivated, they start walking within 100 meters, 200 meters, they become very symptomatic. So this is basically whenever there is a demand, exercise demand, and there is an increased cardiac output, because of the LV stiffness, automatically they're having a pulmonary venous congestion because of elevated LV endosteric pressures, elevated LA pressures. So this goes very classical. And the moment they sit and they relax, they become all right. The moment they rest, they become all right. Whereas in systolic heart failure, they have to come to the hospital, they have to receive a diuretic. They are not going to recover just like that. Either they are doing some salt indiscretion with the existing diuretics, they are not responding, that kind of scenario. Secondly, CAD is overdiagnosed. So we are picking up so many systolic heart failures and labeling them. Whereas whenever we are seeing a patient with a more than 50% EF who is complaining of breathlessness, we don't give due credence to the symptoms. We actively rule out. I do a pulmonary function test and rule out any underlying obstructive air disease. If required, if the CT is showing any COPD, we also get a CT done to look for any interstitial lung disease. When we rule out, patient is breathless. So ideally, it is recommended, sir, as per the protocol. I have told PEFF. So right heart catheterization is recommended. Like when you're doing angio, you can always do a right heart catheterization and check the.
Most
we used
of
to
our
do.
now are done radially.
Gee, we used to, at least in the left heart, we can check the LV and diastolic pressures, which we used to do regularly in PJ Chandigarh as students. But now nobody checks it. Right?
Yeah.
Actually, there is an issue here. Since we are not going for an invasive testing, which is supposed to be the whole diagnostic gold standard for HFpEF, because we do not have an treatment just like a HFpEF. That's why probably we do not have the impetus to go for an exact diagnosis. But as you said, it is correct. But at least we should be able to diagnose it correctly. Treatment maybe with due course of time, some disease-modifying treatment might come up. And what are the cutoff values you are accepting for NT-proBNP?
How much, sir? Pardon, sir?
Cutoff values?
Cutoff values for NT-proBNP.
Okay, sir. Generally, we are seeing our diastolic heart failures in the range of somewhere from 800. We do NT-proBNP, not just the BNP, sir. So we are finding it from the range of 800 to 2000. Okay. Whereas systolic, we are having above 5 to 10,000. 5,000, it starts off from that.
So again, extreme age beyond 75, again NT-proBNP fails. We do not have actually levels defined for 75 or 80 plus. They can have 2,000 as normal, 3,000 as normal. So that is another difficult population other than obese and CKD patients.
Herein comes the echocardiography, which is much more easy to quantify. Sir. We know that there is a severe diastolic dysfunction, and the classical way we have learned in our student days that how to. I've not seen many cardiologists elsewhere grading diastolic dysfunctions. They just write the ejection fraction, RWMAs, that's it. So
personally, I feel that SGLT2 should be the best drug to treat HFpEF because it reduces your weight, it reduces your blood pressure, it lessens the chances of AF, it squeezes actually the tissue edema, which is actually a main problem with HFpEF patients. But even SGLT2, we have seen so many trials. They did not show that it's a very promising drug.
Very promising, absolutely.
Why do you think that it did not work as expected that it should work? It definitely showed benefits in HFrEF, but with HFpEF, it is showing benefit, but it is not showing that great benefits.
Great benefits.
Yeah.
Because it is only addressing the volume status, which is counteracted by your other mechanisms, which is RAS activation, and these patients predominantly have a kind of arterial stiffness, which is not addressed. When you have an arterial stiffness and ventricular wall stiffness, have an underlying obstructive sleep apnea, which is shooting up the blood pressure because of CO2 retention and all that. Those mechanisms cannot be addressed by SGLT2. It can only address a modest weight loss, some extra fluid, which will give early improvement, but it cannot probably sustain the improvement. But definitely my patients have reported a weight loss of 3-4 kgs after starting them. After a month, they feel much lighter and fresher.
So you feel that the SGLT1 plus SGLT2 receptor, that is sotagliflozin, that may have an edge over SGLT2 receptor alone?
But that was studied only in diabetic patients, so we don't have much of data. In the absence of data, can't use.
Mechanism-wise, because SGLT1 is also found in pre part of the kidney and as well as in heart. So that is what they're thinking, that probably that may work for them. And then the latest study, that is Paraglide, where they have used ARNI in specific population, that showed that there is some promising uh, promises with ARNI in HFpEF. Whereas the other trial, that was Paragon HF, it only showed that the benefit was limited to female patients, and then the EF should be more than the average EF, or the maximum EF where the benefit was seen was 57%. And it wasn't very fruitful or very useful in male population, male patients. So why this difference should be in females? It is working for males, it is not working in HFpEF.
So probably, sir, some mechanisms of fluid retention postmenopausal ladies.
Or is it only that the company wants, at least in some it works, so let
But
it
sir,
be,
let me tell you, most of our patients,
smaller study, sub-study, which is
sir,
showing some benefit.
There is a bias because most of the patients of systolic heart failure are male patients. Most of the patients of diastolic heart failure are female patients, because I have not brought in the gender here because we just didn't want to be gender specific. So in our clinical observation, most of the diastolic heart failure patients are females. So that's what I can tell you. But otherwise, I have no other experience in gender. I have not evaluated. I think about it.
Paraglide is the latest where they have evaluated this HFpEF. But again, the investigators have played a trick. What they had done is that they had taken those patients who had worsening of heart failure and then improvement and then introduction or continuation on ARNI. And then it is defined that these patients have an average of I think 40 plus or 47 EF of 57 of 50 plus EF. So initially they had less than 40 EF, and now they have.
You have nailed the point.
This is you kind of.
I want to bring in one point in this. Sir. I was trying to tell. If you remember my first slide, I said that there is a subset of patients who are in reduced ejection fraction who have recovered. Whatsoever was the cause of the reduced ejection fraction, whether it is myocarditis or viral whatever, they have recovered and they are in the mid-range oblique. These are the patients who will more benefit with ARNI. Because these are the patients who will come to us as diastolic heart failure. We will see the EF and we'll decide. Because sir, we don't do the dedicated M mode measurements. I've seen most echocardiographers, when I open the report, I see the LV internal dimensions, I see the EF, I know that. So you have to have a dedicated measurements of the M mode and to decide whether, what is the accurate. And of course, at basal cuts, we tend to overestimate the ejection fraction also.
Actually, as per your pathophysiology also, HFpEF and HFrEF are two different spectra. So those improved ejection fraction or recover ejection fraction of HFrEF, they will certainly respond much to the standard drugs.
Exactly.
And probably Dr. Smith, what he has suggested is correct. They're playing a trick on us.
Exactly.
One issue, I just have a question, Jayachandra, that what you said is valid, that we need to look for all the indices of diastolic dysfunction. We have so many now. Problem is the patient with atrial fibrillation and tiltal ventricular hypertrophy, borderline left atrial enlargement. How you prognosticate this patient is going to improve, or just presence of AF only indicates that this is atrial fibrillation itself indicates that this is a diastolic heart failure if you don't find any cause? I didn't find these issues anywhere. Do you have any idea?
So mostly atrial fibrillation is a consequence of chronically elevated LA pressures, chronically elevated, which are much more common in patients with hypertension and like obesity and definitely preserved ejection fraction. So it definitely complicates because once you lose the atrial contraction, whatever it may contribute 30% or 20%, if once you lose it, because initially it contributes 30%, but as the ventricle becomes stiff, it becomes to 50%. And suddenly in AF, you lose it. It precipitates a failure. So definitely the prognosis with AF is not good. And the only thing is that non-structural, we do try to revert the rhythm, but we have seen certain patients who come back to the AF repeatedly, even after giving an amiodarone and all that. So we know that irreversible changes have occurred. So such patients definitely don't have a better prognosis compared to the ones who revert transiently with alcohol, because so many confounding factors in this: alcohol consumption, you know, sir. So we don't know. I mean, there is so much of, like, cardiac MRI is one modality, probably non-invasive. We can use to study what kind of, infiltration happens into the structures. We don't do, I mean, because we think of it is of low importance, because we are as such overburdened by systolic heart failure. We just decide based on, like you said, AF it's not easy to find out the diastolic dysfunction. In the presence of AF, you cannot quantify. So probably I think AF candidates are the better candidates whom you should do a wedge pressure or LV and diastolic pressure or something like that, just to quantify whether.
So JC, do you feel, though you mentioned that out of 10 you find that 3 have HFpEF, do you feel that, I feel it's other way around, that we have lesser systolic heart failures and more diastolic heart failures, only because we have something to offer for systolic heart failures, that we pick them up and then, throw them drugs, throw them treatment. But in reality, diastolic heart failure is
exactly. You're absolutely right.
But since we have nothing to offer, we actually do not probe into our patients that do they have anything or not.
Yes, sir. You are absolutely right. You nailed the point. I was telling that in my ICU admissions, out of 10 admissions, out of 10, 3 are diastolic. But mostly what happens when a diastolic heart failure comes to the OPD, some kind of diuretic is started. Either it is a Lasix or a Ditor, and they improve very rapidly, and they usually don't reach the hospital. They don't get hospitalized, that kind of thing. Like out of 10 admissions in the ICU, 3 are only diastolic, at least 7 are systolic, because these are the chronic follow-up patients we have. We are continuously coming and going. In a year, they're admitted 3-4 times. So you are right in the prevalence of diastolic heart failure is much more in the community, but we have a bias in picking up the systolic heart failure patients and admitting them.
And actually, cardiologists, the general physicians, they were not well appraised of the significance of diastolic heart failure. Because there is a general tendency to believe that diastolic heart failure is not very serious. Prognosis-wise also is all right. And symptomatic status, they do not deteriorate. But we have seen patients with HFpEF, they can present with acute deterioration.
Absolutely. So since you're so much into HFpEF, why don't you pick up something? This actually, before we inject or before the resident injects Lasix or Ditor, we need to, that is why my question was, how do we pick them clinically? So we need to pick them clinically before anyone treats them and, alters those.
We have to, the best part is point of care echocardiogram. We should teach the residents how to do point of care echocardiogram at the reception in the emergency. Just document the diastolic function, do the NT-proBNP. At least if extreme ages we cannot really apply CKD, we can, but rest cases we can apply. It's pretty much, I mean, all the cases which we have done, we've given us very clear thought process ki, yes, this is not systolic heart failure, because the values were in that range.
JC, it's a personal observation and personal, I should say, recommendation. I ask my patients whether while tying shoestring, do they get breathless?
Correct.
I ask them whether they, while walking and talking on phone, they are unable to talk. So these are, before a resident echo comes, these are the points that we need to ask our patients. And, I don't claim that they'll be, but they are pointers.
They are pointers.
Why don't you bring up a study and have all of us involved or many of us involved, where we can have clinical pointers.
Correct.
As we have it for systolic heart failures.
Correct.
And then we can, we can do subsequent echo, subsequent NT-proBNP, subsequent treatment, and we apply a AI algorithm so that we can come out that if we can come out with a good scoring. So if it has a, that shoestring shortness of breath, let's give it a score of 3 and see the weight. Or talking, walking, let's give it a weight. So let's list out these symptoms. I think we'll have a very good paper made out of it and a good JC score for a HFpEF.
That will be very cost
Yeah.
effective.
A little. The only problem is little subjective, sir. It's not very objective. Number one, and there are a lot of problem.
So we can
Depends.
make it subjective.
Yeah, and
We
a
can make it
little.
one tying shoestring is straightforward. We can make it like you can climb one flight of stair, or you can walk 100 meters before you become aware that you are not able to
Absolutely.
talk into
Absolutely.
So we can make it subjective and
Absolutely.
I think we can discuss on those nitty-gritties, how to go about this study.
Absolutely. Secondly, sir, systolic heart failure patients, the predominant symptom, once they are compensated, is fatigue. They don't feel breathless. Diastolic heart failure, because they have a more incidence of RV, क्या बोलते हैं, pulmonary
celebrations.
hypertension, they have more of dyspnea rather than fatigue. They have dyspnea.
Yeah.
And then
What do you
OSA.
do about a point when a patient needs increasing dose of diuretic and the renal function is preserved, but they are taking, they are responding to more higher dose of diuretic. So what do? You maintain on higher dose of diuretic, or you calm down over a period of time?
Sir, basically, there is a condition called diuretic resistance. If the patient has been subjected to diuretics, sometimes we have patients, especially we have in systolic, on a couple of diastolic, they have a diuretic resistance. Probably the gradient is washed away from the loop of Henle, it is not acting. So in such a scenario, what I do is I add a sequential diuresis. I add another diuretic which acts on the DCT, something like metalozone or thiazide, and then these patients they recover very fast. They excrete the volume, and then the requirement comes down. We keep monitoring the urea every other day in the ICU, and then we taper off these things. That is one thing I found. There are a lot of people, especially CKD patients, have diuretic resistance. CKD patients.
So another promising drug should be spironolactone, eplerenone, or finrenone.
Absolutely.
Purely being antifibrotic, probably that they should be hitting at the point where LVs become stiff. But you showed TopCat, not very promising result. And other eplerenone, probably eplerenone is another drug which is
it's a cost factor.
It's a fancy drug. It's a fancy drug. No effects. But finrenone can be one of the drugs which can be promising. But again, clinically it has not shown benefits.
Most of these patients, they have diabetes and CKD. The moment we start aldactone, if they have a renal tubular acidosis, we'll land up in hyperkalemia. That is the biggest problem. We have noticed whenever we started a low dose of aldactone, they invariably have some renal tubular acidosis. They come with hyperkalemia. So then again, the whole cascade starts.
I think all students of Dr. Ajay Bahl would not go beyond 12.5 of a spironolactone. It's very rare that that was his teaching. I had never exceeded that, and I never had a hyperkalemia. I may have gynecomastia, but I never had a hyperkalemia. Rarely a hyperkalemia that would require treatment rather than only treated with withdrawal.
What is the clinical response then?
That's me.
Yeah, if you are using a slightly lower dose.
Clinical response is good, sir. I mean, 12.5 is a good.
The Indian dose. Patient we have seen the dose which we used to follow in PGI, MMT and all. In our day-to-day practice, we are not being able to follow that kind of dose, especially in HFpEF.
Correct. I only remember giving 25-50 aldactone in RHD patients, 25 in systolic heart failures, but diastolic is all 12.5 minimal.
So, Dr. Sunip Banerjee is making a comment.
Mike, I think his mic is muted.
Sorry. Yeah. So I was telling that TopCat actually just missed the hazard ratio for a small number, and it was done long back. So probably we must revisit this spironolactone in more of this patient, keeping the Saujatya also feels, and we also practiced in the same way, 12.5 or maximum 25 milligram. But it probably should be used more often than. And if in a diastolic heart failure, if I have to choose ARB or spironolactone, I will choose spironolactone and stop ARB. I think this is again difficult to make this comment, but definitely this probably will be better for the patient symptomatic benefit.
And the same question I'll ask for HFrEF, spironolactone versus ARB.
No. The thing is that there, if you give ARNI, really the chances of hyperkalemia comes down. But as JC said, that this renal tubular acidosis, it's a proof of challenging this medicine and then having hyperkalemia. It's the real problem. And until we have a real potassium binding, effective, compliant drug, we are stuck there.
Do you feel
And
Finerenone?
potassium restriction is a very difficult. Yeah, Finerenone is definitely in patient with diabetes, CKD. The problem is nephrologists, they don't want to use it still. But I think we must more use it. And
again,
up to 20 milligram, not in 10 milligram.
The hardcore primary points, Finerenone has not shown that it was beneficial. It's only for the soft points, like again, same heart failure, hospitalization, like those things, fine heart.
Yes.
We do use aldactone for uncontrolled hypertension. So that works really well. So when we add ACE inhibitor CCB, patient is not getting control, then the third options are very bad. Minipres, clonidine. So we add aldactone and we monitor the potassium.
30% of the resistance hypertension would be because of hyperaldosteronism.
Therefore,
antagonizing it would give you result in 30%.
Correct.
And doxazocin, LHAT, it did not. It was actually a drug which was not to be used. So it ends up there. And I don't know anyone of us ever has used a doxazocin now.
Doxacat is no more available from Cicla.
It's not available.
My one last question to all of you. Do you think that we should write dapagliflozin in HFrEF and empagliflozin in HFrEF? And if it is so, should we continue 12.5 milligram of EMPA, or if the patient tolerates, we should give 25 milligram, that gives a better result? These are not answered, or this has not been, I have not been able to find out this thing.
Yes, you would like to comment? The study, whatever is available, they started only with 10 mg. But if we are using 25 mg as of now for poor HbA1cs, like you want a more weight loss, the diabetic control is poor, the insulin requirement is high. But generally, we have not this is a point I've not thought about before. So definitely we'll think about it.
So personally, I feel it's a class effect. It's a class effect. Whether you use DAPA, you use EMPA, you use even the other one, the Cana. So the reason is, the trial design have medico-legally it's different aspect that they are different in whenever you have a certain GFR, one EMPA can be used till 20, DAPA can be used till 30. But I feel it is because we have not tested in those trials at that level. Had it been tested, probably it will prove its work there also, one. And then it's a purely class effect. The effect is not, it's a endocrinal effect, I would say. It's not exocrinal effect, that the effect is limited to renal. It squeezes fluid, the SGLT2 inhibitor squeezes fluid out of tissue against the diuretics that squeeze fluid out of intravascular compartment. So we are not in, that is why our patients develop hypotension, or whenever we try to give diuretic to a diastolic heart failure patient, excuse my saying diastolic because it's a habit. So HFpEF patient, whenever we give them diuretics, they develop hypotension. because we have reduced the intravascular part of the liquid environment, and so they develop hypotension. Whereas when we use SGLT2, we are not doing anything to the intravascular compartment, but it's the tissue edema that we are reducing. So lungs are decongested, organs are decongested, the venous viscera are decongested. That is why I had asked you that question: why is not SGLT2 proven itself to be the best drug for HFpEF, whereas it hits at all the points that result in HFpEF? It reduces blood pressure by 4 millimeter Hg. So it acts as an antihypertensive, it acts as an anti-diabetic, it reduces atrial fibrillation, it reduces tissue edema. So it should be the ideal drug, but none of the trial is actually giving us hard clinical outcomes which can prove so. There are outcomes which, when you study those studies, you feel that, we had to conclude positively for this drug, and probably therefore we have brought in some subsidiary or secondary targets to prove that yes, the drug works. The same way I feel for army. If it is not working for above 50 EF, let's accept it. Why only female? Then till 57 EF, 50 to 57, it will work. Why once the person has worsened EF, now has improved EF, now we'll label the improved EF. They have changed the definition. Now improved EF is also preserved ejection fraction EF, FPEF.
Which is not true scientifically.
The only
So
one.
why label it? Let it be improved ejection fraction. Why label it as preserved EF?
So the one problem, the one problem with use of SGLT2, because most of these patients are concurrently on metformin. So there is a theoretical concern of metabolic acidosis with use of both the agents simultaneously, metformin and SGLT2.
Metformin, if you go into the literature, has never caused metabolic acidosis.
In combination,
it is only fenformin.
Absolutely.
We have never stopped metformin in our heart failure patient, in our cath patient. So that has been a theoretical concern always.
There is a mention
I don't
that
think any of us still stops metformin before we take up the patient to cath lab.
So they say that there is one concern regarding euglycemic ketoacidosis. That is the word used for the combination of metformin and SGLT2. So we had seen 1 or 2 cases. Of course, the patient was underlying, CKD with a creatinine clearance of 35-40, where we can use SGLT as of now with a creatinine clearance of 35-40.
So SGLT2, you have to be very careful about the signals.
Yeah.
If that is Dr. What Sunip is telling, I think we have a lot of evidence on the use of all these drugs. And since there is no head-to-head comparison, so scientifically we cannot say which is good or which is bad. But depending on the clinical experience and the response we get, I think we are quite legitimate. If we change the order or the dose a little bit, and if we find a good result, we can continue. Though we do not have enough evidence to vouch for that. But in our personal clinical practice, you can jolly well go for that. So what are you doing, Sunip, actually?
Yeah, no, we want to listen from Ashish and Saujatya. They are remaining silent till their opinion.
Even Dr. Pranab also joined, and then
Pranab, please.
Good evening, sir. So it was such a nice talk, and actually there's not much evidence regarding what all. There's no medicine which is class 1 level of evidence. So the discussion about therapeutic, the problem is, I think heart failure with preserved EF is not primarily a cardiac disease. There is there is a stiff heart and systemic disease, which is causing fluid accumulation or other factors which lead to this. And that is the reason that even if you control the cardiac part with SGLT2 inhibitor or with ARNIs or fibrosis reducing agents like MRAs, we are not getting that good effects. And even mortality benefit is not being seen, is because the primary condition itself is severe enough to cause the harms, and long-term mortality, that's why, is in these patients is almost similar to heart failure with the reduced EF only. So that's my point is like because of systemic disease, the primary cause.
Absolutely.
Yeah. That's why we are not getting, we don't expect, and it's less likely that there will be any drug which will like outrightly change the scenario, though SGLT2 inhibitor definitely has like given us some hope. What about like devices, like those patients who have refractory symptoms, not responding to diuretics, and like LA decongestion with some shunts? What are your views about that?
Unfortunately, that has become a negative trial.
Yeah.
Anyway, Jayachandra.
I think you should unmute the mic, sir. Mic.
I think so far I came to know this shunt, intraarterial shunt became a negative trial, even coronary sinus reducer. So,
Correct.
but maybe the selection was for a long-term result. We should have it. I don't know.
Probably that was based on the idea that we can have, it decompresses whenever we have a high RA pressure and RV pressure. And so it should also work on the other way around. When we have an increased LA pressure, it should work other way around. But I feel both the chambers are very different. Both the sides are very different in their pressure generation. So same idea may not work.
Yeah.
No,
So
if they refractory,
it
they're
is
very
here
likely
the
to do.
RA and LA, whenever the RA pressure is high, it gets balanced. So RA pressure would be systemic. I mean it would be close to the LA pressure or higher pressure in LA. But when we have a normal physiology on the right hand side, but an increased pressure on the left, the pressure difference between LA and RA would be huge. So these devices probably will not serve the same purpose.
Yeah.
The flow would be torrential or flow would be high.
No, if a HFpEF patient becomes refractory, they're very likely to have PAH and right heart failure. So the shunting, the creation of a shunt may not work.
Yeah. So
Excuse me, I got a call. Can I take leave?
Sure, sir. Sure.
It was very nice interacting with all of you. We'll meet sometime.
Join next month on 4th Friday. August and January, we have special session where we honor one of the batches.
Okay. No, I know. I am a regular follower of your WhatsApp.
Yeah.
Okay.
Nice.
Bye-bye, Dr. Sunip, Dr. Jesse.
Thank you.
Yes, sir.
Thank you, sir.
Thank you. Great discussion.
Good night.
Thank you, Smith.
We can also close if we have.
Yeah.
The comments.
Thank you.
Okay, I have initiated a cascade.
Yes.
Closing down.
No, one important message to Smith. Keep it up,
Sir.
and just go on doing these things. Thank you.
Sir, it's now, this, I'll pass it to Saujatya. Saujatya is looking after this part of online masterclass.
Yeah, I know.
Yes,
Only
you
Yeah. Thank you.
Thank you.
Good night. Thank you, Jesse. Nice presentation.
Bye. Thank you.
Generated a lot of discussion.
Thank you.
Yeah.
Good day. Good day.
Thank you.